Good afternoon, everyone. Thank you all for joining the TxRx Echo brought to you by the Center for Substance Use Training and Telementoring, also known as CSET by Be Well, Texas, in collaboration with the UT Health San Antonio Echo program. My name is Angela Cruz, and I will be the facilitator for today's session. A few housekeeping items before we begin. Please do introduce yourself in the chat by entering your full name, affiliation, and email. We love to see where everyone's joining in from. Please remember to stay muted unless you are speaking.
That's me. Back.
We encourage using the chat and or the raise your hand feature to pose questions and share your perspectives and resources throughout the session today. We'd love to have everyone with their cameras on as this increases connection and engagement, though we completely understand that some situations don't allow for that. But if you're able, we'd love to see everyone's faces. If you're having connection issues, please privately chat our wonderful Echo IT Karen for further assistance. As a note, these sessions are being recorded and they will be shared on our website. Therefore, to ensure privacy, no personal health information will be allowed at any point throughout the session. And this includes things such as names, addresses, birth dates, and other identifiable information. And additionally, the slide presentation will be made available after the session today. It will be uploaded and shared on iEcho for future reference, and it'll also be shared in a post-session email. At the end of the session, the Echo team will be sending out a post-session survey link. We kindly ask you all to complete it because they do provide us wonderful feedback on how to refine these sessions, topics, and the curriculum to better address your priorities and your interests. With that, we'll go ahead and move on to some team introductions. I'll begin with Dr. Walker.
Good afternoon, everybody, and happy holiday season. Crystal Walker, I am a physician associate with a doctorate of medical sciences in addiction medicine, and I am currently the director of substance use disorders, clinical and medical services for MHMR of Tarrant County. So happy to be here.
Thanks, Dr. Walker. Dr. Chowdhury.
Hello, everyone. I'm Ali. I'm one of the physicians here at Be Well, Texas, and I am the Director of Adolescent and Youth Clinical Services here. So glad to be here and learn from everyone.
Thank you, Dr. Chowdhury. Good to see you. Long time no see. Um, I say that as a joke because I just saw him like a couple days ago. And Dr. Kowalchuk, who will also be serving as our didactic presenter for today.
Hi, Alicia, Dr. Kowalchuk here in Houston at Baylor College of Medicine, and I'm an associate professor in family and community medicine, boarded in family and addiction medicine, and I'm the medical director of Santa Maria Hospital.
Thank you, Dr. Kowalchuk. And we do have a couple other hub members that will probably be joining later, so we'll introduce them at a later time throughout the session. So thank you all, and thank you all that have introduced yourselves in the chat. And finally, Echo is an all teach, all learn environment, and we do encourage everyone to participate in today's conversations, raise questions, and share resources. And let us always make every effort to continue having this space that is respectful and safe for all of us to learn together. We'll get started with our didactic presentation. Dr. Kowalchuk, the floor is yours.
Okay, so I think I'm sharing screen now, hopefully. Okay,
Yes,
great.
that looks good.
All right, so we're going to be talking today about helping patients manage their alcohol use risk during the holidays. So how can we toast the holidays and not get toasted ourselves, right? So we want to keep our patients safe during the holidays. No disclosures, and the views expressed don't necessarily reflect official policies, et cetera, of UT Health San Antonio, DHHS, or Texas Health and Human Services. So our learning objectives for the next 15-20 minutes is to list risk factors for increased alcohol consumption over the holidays, describe some stressors for persons in recovery that can arise over the holiday season, and discuss some ways to help our clients or patients decrease their risk for increased drinking and our return to use during the holiday season. So what are the statistics around alcohol use during the holidays? I thought it was interesting preparing for this talk today that a lot of the data that's available, and particularly more recent data, comes from the insurance industry rather than from kind of academic publications and IEEE, et cetera. So that was kind of interesting and really tells us about the risk of the increased drinking around the holidays and who has a stake in decreasing that risk beyond patients and families and us. So from Blackout Wednesday, which is the new term for me, but I guess it's known out there, is the Wednesday before Thanksgiving through New Year's Day. Over 700 individuals in the US are injured or killed in DUIs daily. And that's 2 to 3 times the rate of DUI injuries and fatalities in the rest of the year. The other data you see presented here is from a 2024 survey by one of the insurance industry organizations around drinking around the holidays of US adults. Over 1,000 were surveyed across the US among varying demographics. And you can see that 55% of folks in this survey said they drink more during the holiday, 36 about the same, and about 9% less. Almost half, well, actually over half, have ever regretted drinking too much during a holiday event. And almost half has been sometimes, 5% or more express that they often have regrets around their drinking. And you can see the number one holiday this season for drinking is New Year's Eve, followed by Christmas and Thanksgiving. And then we have some other holidays there from around the year. In this survey, men were more likely to binge drink, as were Gen Z. And then again, this is again specific to the holiday season. Interestingly, men were almost 2.5 times more likely to experience alcohol-related conflicts when drinking. And the survey also asked about whether folks who attended work-related holiday events preferred that there be alcohol or not. And a little over half preferred that there was alcohol at their work-related social events during the holidays. Again, looking at why people said they used alcohol around the holidays, increased their drinking, almost half. And you can see people had multiple reasons why they used, because this doesn't add up to 100% here. They were allowed to choose multiple reasons. Mostly it was to celebrate and connect with family. Some used it to feel happier or more relaxed, others to socialize. About 10% was just for tradition, and 7% to relieve stress. Men were 38% more likely to drink for the sake of enhancing connections to friends and family in this cohort. And then looking at whether folks have ever used alcohol to cope with holiday-related stress or anxiety, it was not as frequent as we might assume. And again, this was general population data, not folks with a substance use disorder or alcohol use disorder history. But we still see over half have at some point used alcohol to cope with holiday-related stress or anxiety. So at least on occasion. So what are some of the risk factors for alcohol use during the holiday season? And this includes risk factors that are more general for society at large, and then also risk factors that are very specific for folks in recovery or with alcohol use issues already. So we see family traditions and patterns is one of the biggest risk factors. Social expectations beyond family units, increased access and exposure. So there tends to be more alcohol available at social events, And there's also a lot of advertising around alcohol and specialty drinks, etc., around the holidays. Bereavement is another risk factor for alcohol use during the holidays, particularly if a loss occurs during the holiday season. And also, the first year someone has lost a loved one or loved ones can be particularly difficult during that first holiday season, although it can recur from holiday season to holiday season. Early recovery, particularly if folks are still in post-acute withdrawal or not getting adequate care, can be a real risk factor. Isolation and loneliness. And for folks in recovery, particularly if they don't have a well-developed recovery community and support system in place with their recovery going into the holiday season, that can be triggering if they're trying to avoid maybe what they've usually done for the holidays, which has involved using alcohol, events with alcohol, and folks that trigger their alcohol use. And then we have the stress. And stressors can include family conflict and triggers, financial strain. So there can be a lot of pressure to spend during the holidays. And then just really unmet or discordant expectations. So this expectation that the holidays, are going to be vibrant and festive and filled with activities. And if that's not happening for you, it can feel jarring and stressful that you don't seem to be having that quote unquote ideal holiday. Another risk factor for drinking during the holidays is seasonal affective disorder. We see this probably a little bit less in Texas, although finding the actual stats was pretty difficult. This was from a major review article of SAD that was published, I think, in 2023. It looked over about 5 years, summarizing about 46 articles. It is considered a subtype of major depressive disorder. And prevalence ranges in these studies were anywhere from 2%, that was a study out of Saudi Arabia, which is more closer to the equator, and 21% in Norway, which is very northern latitude, right? So risk factors, the most prevalent age range is 18 to 30-year-olds, women more than men, a family history of SAD, and then living in northern latitudes. Insomnia increases the risk for SAD, inactivity, and then interestingly, chronotype. So night owls are at higher risk of SAD than early birds, which is interesting. Symptoms, decreased interest or pleasure, depression, feeling down, sleep changes, either too much, not wanting to get out of bed, etc., or too little, decreased energy, increased or decreases in appetite, and trouble concentrating that are related to the winter, late fall and winter season onset, and then relieved with the onset of spring or summer. Treatments include light therapy, and there's some very specific dosing for the light therapy, which I thought was interesting. CBT, antidepressants, exercise, and exposure to natural light. So how do we help our patients mitigate their risk for alcohol use during the holiday season? This really involves a lot of understanding and taking their own personal risk history and helping them think about what their personal risks are, and then helping plan for strategies to address those specific risks, because everybody's risks are going to be a little bit different. So more broadly, helping them plan to stay connected or engaged with recovery supports if they are in recovery. Practicing self-care, so not letting the busyness of the season maybe crowd out normal self-care activities and staying engaged with self-care. If they're going to be attending events or hosting events, ensuring that there's non-alcoholic beverage options available. And that might mean having a conversation with a host up front, or just bringing your own to ensure that you'll have something there for yourself. Setting reasonable holiday budgets in advance to make sure that you're not going to run into financial stressors created by the holiday. You may have some underlying financial stressors that are just, seem more acute or hard to deal with during the holidays, but certainly don't want to add to that by holiday spending. Really thinking about creating new traditions that don't center alcohol. If historically traditions that particular person has enjoyed or participated in during the holidays have really centered alcohol. Having and practicing a non-drinking or using script. Again, patients that may be, spending time with family or friends, where drinking is prevalent or using other substances. How are they going to refuse that one person who insists on, yeah, just come on, let's go, let's have fun, etc. Right? So knowing that what they're going to say and maybe helping them practice that in advance can be helpful. And then, for some patients in recovery may really benefit from working, more than just a, one-off conversation or during part of a visit discussing the issues around the holidays, having more intensive sessions with the treatment team, either the clinician, their therapist, their recovery coach, and peer supports on that. Prioritizing self-care and really deciding. Sometimes it can be really hard for folks, particularly early in recovery, to decide, do I forego going to a major holiday function, whether it's family related, work related, because I know there'll be triggers, and I need to prioritize safety and self-care, or do I prioritize those relationships, and when will I be ready for that, right? So sometimes there's a lot more to unpack than, in a brief discussion. And so we want to start these discussions early and help give people the time and resources needed to navigate successfully. So what we're really trying to do is help patients avoid our little raccoon's friends situation, right? Isolated, decided to make some really unhealthy and illegal choices around breaking into a liquor store and imbibing and ending up with a really not good outcome, went viral on social media. I know we don't want this for any of our loved ones, our patients, etc. So how can we have conversations with our clients or patients around this and really open up the dialogue? And this is something I'm sure most of you working with folks in recovery in your work do regularly. I really start thinking about this with my October, November visits with patients. Let's talk about the holidays and what's coming up and just touch base. So, kind of some scripts to get into the conversation, keeping it open-ended. How are you feeling about the upcoming holidays? I'm curious, tell me how you or your loved ones usually celebrate the season. What are some of these traditions? How would you like the season to be different, if at all? What, if any, new traditions are you planning this year? What or who is stressing or worrying you this holiday season? What are you looking forward to? Who are you looking forward to connecting with? What are some self-care activities you see yourself doing this season? What are your goals? So some folks, as we'll see in the case coming up, their goal may not be total cessation. Or if alcohol has not been their DOC and they're in recovery from other substances, they may want to still be able to moderate and drink. And so we really need to know what their goals are around the season and with their substance use. And how are you planning to handle if someone offers you a drink, right? So these can get us into the dialogue in an open way that supports patient sharing. what's going on in their lives and what's important to them. And then we can go from there about specific planning. And then, after the holidays, I like to debrief with my patients about how things went, right? How were your holidays? How'd it go? I mean, I'm asking this month how Thanksgiving went and learning about a lot of interesting things. And I'll ask next month about how, the end of the year holidays went. Sometimes it's helpful to, open up some space for our patients related to that. It can be really common experience to have cravings, to have return to drinking slips or full return to use during the holiday season. Was that an issue for them? Did any of that come up for them over the holidays? To give that permission to share maybe something that's not so comfortable or they don't feel confident about sharing in the session. What would you do differently next year, if anything? How would you like things to go differently next year? What's your favorite memory? What's the favorite thing that happened this year during the celebrations? Or who all did you most enjoy connecting with over the holidays? So also some positive reflection, right? So really focusing on strengths-based. And what are you looking forward to in this new year? So it lets us transition into planning for next steps in the recovery. These are some resources I found online. There's some great infographics and posters that it's probably still not too late to print out and put up in your offices if you think that would be helpful. SAMHSA has a whole series, which was really nice. And it comes in a red and white theme too. The blue kind of went better with the slide template today. And those are my references. And I wanted to leave some time at the end. I think we still have a few minutes for folks to share their tips, because I'm sure there's a lot of expertise in the room around this. And, what experiences folks have had in their work with patients or clients around alcohol use and talking about the risk for return to use during the holiday season.
Dawn, I see your hand raised. Go ahead.
Well, a couple of tricks that I learned a long time ago in my own recovery, actually. Two things are really simple. Number one, if you're at a party and everybody's drinking, if you drink Dr. Pepper, nobody will come and try and pour Jack Daniels or anything else in it, because there's only a couple of drinks that work well with Dr. Pepper, and most people look at it and say, ooh. The other thing is if you're going out to eat at a restaurant or something and you're relatively convinced that at least some of the people are going to be ordering alcoholic drinks or whatever, if you order first and order an alcoholic, half the rest of the group will follow you instead of whoever orders their alcohol first. And I've used that for many years, and I've never had anybody try and push me past that. So just a couple of tricks I always try and tell the clients about. Thanks.
That's wonderful, Dawn. Thank you. I enjoy a good Dr. Pepper. A nice, crisp, cold Dr. Pepper is always a treat. Any other insights or resources from our audience?
It's Dr. Miramontes from San Antonio Fire. So the holidays, as you talked about, the Wednesday before is a big deal, but also all through this season, we see an increase in cardiac related activities because of alcohol. Alcohol is a direct cardio toxin and a myocardial depressant. So we see a lot of exacerbation of CHF during this season. Couple that with the dietary changes that go along with the season, increased salt, etc. That really goes together. We also see more cirrhosis and issues as people either go off their very specialized diets, eat more salt than they used to, or go back to drinking. So all of those, the medical side is somewhere you might have to ask them, well, how much alcohol do you drink? They're there for heart failure, but you may have to ask that question. Or have you used methamphetamine or cocaine? And is that why you're here, perhaps, in the emergency department or in the ICU with acute heart failure? So just keep that in your differentials, the point.
Exactly. And there's even a name for, alcohol related heart problems, particularly around holidays, called holiday heart, right? So we see increased rates of onset of AFib, et cetera, during the holidays. So great point to not forget about the medical complications because they're pretty severe. Other thoughts folks have or tips?
I just want to say yeah, thank you for the topic. Great topic. It's just really, it's just so important, working in residential and outpatient, like it's so important to be able to talk about this, because the holidays are such a big trigger for so many people, you know. And so thank you for that. And I'm gonna, I was looking at the questions on the debriefing and, make sure that I do that with my patients, also, and I have, since like after Thanksgiving and like I'm glad that you talked about SAD also, because I've had some patients experiencing that too, and especially, and like a week ago, we had the weather here. It was so dark and gloomy and cold. I started feeling like I was like, oh my God, I'm like depressed. So I could imagine being in that like that all the time. So I'm so happy that sun's out. Yeah. Thanks, Dr. K.
No worries, Dana. Thank you for your work. I think, I didn't go into very specific details on, alcohol avoidance strategies. I kept it more general. I think we heard from Don some really concrete strategies. I think another good one that I saw come up over and over again, and I've heard my patients talk about it and have family members in recovery that's been one of their big strategies, is just volunteering to be the DD, the designated driver. Everyone loves the designated driver, and that's, they don't expect you to drink. They don't want you drinking if you're the designated driver. And I think the other thing I've learned from my patients, and again from loved ones in recovery, is just how surprised they are when we've talked about it afterwards at how little people have really noticed if they just keep something bubbly in their hand, nobody notices or asks what it is or that it's not alcohol. There may be that one person that they need to have that script for and be able to whip it out and use it, why they're not going to drink or just, continue to polite refuse. But it's not it doesn't end up being as big a deal for a lot of folks as they thought it would be once they get through those first couple of social situations.
Thanks, Dr. Kowalchuk. And Kim brings up a wonderful exercise. She says she likes to practice with clients how to role play to prepare for social gatherings and what to say when offered an alcoholic drink. And to have a drink in hand that is not alcoholic, even saying I'm the designated driver. Everyone loves the DD and wants to keep them safe, so that's wonderful. And clients tell me family gatherings are most challenging for trying to get past that. Remember, no is a complete sentence. Yes, very true, Esteban.
Love that.
Yes, and that's wonderful. Keep those thoughts, those phrases that you share with your people, with yourself, with anyone you may know that are helpful to politely decline, politely say no. Thank you all. Thank you, Dr. Kowalchuk, for your presentation. We'll be moving over to announcements because we have quite a few for today. Karen, if you can pull those up, por favor. Thank you. To claim CME credits for today's session, please ensure you have a registered account and then text attend 10101-334 to the number on the screen no later than midnight tonight. When you complete our post-session surveys, you are helping shape these sessions around your needs and interests, and your input does help us make this Echo series even better for you all. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics. To request technical assistance, please complete an online request form using the link in the chat or by scanning the
Look right here.
QR code on the screen, and we'll be pleased to help you with that. Next slide, please. CSTAT offers you all the opportunity to present any challenge your organization is encountering and to receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation as we will provide you with the case form to fill out to assist you with your case presentation. Please email us using the link that will be shared in the chat if you are interested in presenting a case at one of our sessions. Next slide, please. And CSAT is pleased to introduce Proof and Progress, a recovery science webinar series, a 6-part online learning series exploring key research priorities in recovery science identified through a national agenda setting process led by the Peer Recovery Innovation Network, also known as PRIN. We invite you all to join us for the inaugural session, Availability and Effectiveness of Peer Services Across Diverse Settings, on Friday, December 12th, tomorrow at 12 p.m. Central Time. To learn more and register, scan the QR code or visit the website using the link that will be shared in the chat. Next slide, please. Join us for the next Texas session featuring Terry Scogan from Torch as he discusses the evolving needs of rural Texas communities. Mark your calendar for Tuesday, December 16th. Scan the QR code or visit texas.org/session to learn more and register. Next slide, please. And this is a call for presenters for the Texas 2026 Symposium. This closes tomorrow, Friday, December 12th. We invite professionals across substance use and behavioral health fields to submit a presentation and/or poster proposals. Share your innovative solutions, emerging research, and collaborative approaches that advance substance use care and recovery in Texas. Submit your proposal today using the link that will be shared in the chat. Lots of links being shared today. Next slide, please. And Texas 2026 is officially open to sponsors and exhibitors. The Texas Substance Use Symposium will be taking place March 2nd and 3rd in San Antonio, Texas. If you are interested in learning more on how to become a sponsor or exhibitor at the symposium, please visit the website using the link that will be shared in the chat for more information. And finally, there will be no TxRx Echo session on December 25th, as that is Christmas Day and in observance of the holidays. We invite you all to join us in the new year for our next and first session of the new year on January 8th for a presentation on integrating recovery services in mood treatment. Thanks, Karen. And now we'll go ahead and move on to our case presentation. Dr. Luckner, once Karen shares the case, if you could introduce yourself, please, and then walk us through it. Thank you.
So while this is starting, I'm Dr. Ralph Luckner. I am an internist in the rural Texas Panhandle. I treat medical conditions and also substance use. And today we'll be talking about a case from my clinic where we have a patient who's a longtime alcohol user. He drinks very heavily, and he's interested in decreasing his alcohol consumption. So I don't know if we can see. Yeah, we can see everything. So he's a 46-year-old male, white. He has a number of issues, and as we go through this, there are a few questions that I want to introduce. One of them is how to best manage alcohol withdrawal risk in a patient with an episodic binge drinking pattern who has poor medication adherence. specifically to naltrexone. And can everybody hear me okay? Hopefully, and a history of withdrawal symptoms after holidays. Strategies for improving naltrexone adherence during the holiday periods when patients tend to skip doses intentionally to drink more, and then appropriate anxiolytic management given the patient's request for alprazolam or Xanax, as it's commonly called by patients, but concurrent alcohol use and previous panic episodes. So in terms of his current and past substance use, he is a longtime smoker. He smokes half a pack per day, and he's been trying to cut back. He has a 20-year history. And alcohol, he drinks 24 alcoholic beverages, beer specifically, per week, daily evening use for 34 hours. He says that without alcohol, he can't sleep. He can't calm down after work. And he tends to drink more heavily during certain times, like weekends. His audit C-score was 11 out of 12, and he has a history of withdrawal when attempting to stop. He's trialed medical marijuana, and it hasn't really helped him sleep or come off the alcohol. And he has prior experience with prazolam, and he was asking me for a prescription. Skipping ahead to his substance use disorder diagnosis. First diagnosis, alcohol use disorder, severe, F1020. He also has a nicotine use disorder, and those are his substance use concerns. So co-occurring mental health diagnoses. He has generalized anxiety disorder. He also has panic attacks, panic disorder. He has moderate recurrent major depression. It's lifelong. He has obsessive compulsive disorder. He has PTSD, and I don't know why I listed alcohol abuse again, but clearly that's part of his picture. So in terms of treatment, I have had very good results with naltrexone for people that are trying to stop decrease their drinking. And I prescribed him naltrexone initially 50 milligrams and then went up to 100 milligrams daily for alcohol craving reduction. And he says that when he takes the naltrexone, he drinks about 75% less. Basically, he just doesn't want to drink as much. However, when he is in a holiday situation like Thanksgiving here recently and coming up with Christmas and New Year's, he doesn't take the naltrexone because his family drinks heavily and his friends drink, and he wants to drink. He doesn't want to be somebody who's not drinking. So he has poor adherence. He skips doses on days when he plans to drink more. As far as hospitalizations, he's never been hospitalized for this. He's been counseled extensively on alcohol use during clinic, reducing consumption. He's very confusing to me in some ways because on the one hand he wants to quit drinking, but then he doesn't, and so there's some gaps in my understanding of his motivations at times. But I do try to protect all my patients who drink heavily with thiamine, 100 milligrams daily to help prevent alcohol-related dementia, Wernicke-Korsakoff syndrome. I've also used chlordiazepoxide for potential withdrawal symptoms. I've prescribed that to him as a long-acting benzodiazepine. Clonidine, 0.1 milligrams sublingual for withdrawal symptom management, specifically blood pressure going up quite a bit. And education on alcohol binge risks has been part of his treatment, and counseling on the medication adherence importance. So societal and social conditions and psychiatric history. In Texas Panhandle, drinking alcohol is very popular. A lot of people drink, and a lot of people drink very heavily. Support systems, he doesn't really have a support system that doesn't involve drinking alcohol. His family drinks heavily, and one of the things that's bothered him is his father recently passed away. And he's been dealing with bereavement, and also his depression has gotten worse. I have, let's see, alcohol sole effective method for relaxation and mood regulation. So he does have a daily pattern that he needs to follow if he wants to sleep and not feel anxious in the evenings. And I've talked to him about alternatives like an SSRI. And he says that when he took sertraline in the past, he was not as competitive at work. He would kind of just let things go, and he didn't like that about himself. He didn't want to change his personality. He's currently on buspirone. He had been on 10. I recently increased him to 15 as needed for anxiety. He takes one. He can take up to 3 per day. He has a history of panic attacks that he doesn't really associate them with alcohol, but clearly it's a potential aggravating factor. He self-diagnosed himself with OCD. I haven't really treated him much for that. And given that the treatment often involves SSRIs, it may be quite difficult. He's not really interested in seeing a counselor or psychiatrist, so it's been a bit of a challenge. PTSD for 20 years, recent bereavement, father's death 1 month ago. That was when I prepared this, and so it's been a couple of months now. His PHQ-9, he reports a 4, which is a low score, and the GD7 is 4, but I think that some people, and I think this is the case here, they tend to answer questions the way sort of to please the doctor or to not get in trouble, and they're maybe not as open as they could be. So has the he's got some other. Can we scroll down further? Further. All right. So we've talked about the fact that he skips naltrexone. He is taking lisinopril 20 milligrams. And he doesn't check his blood pressure at home very much, but I've encouraged him to do that. We've talked about the alcohol, the audit C being elevated, and then it's not uncommon for him to present to clinic with a blood pressure in the 150s, 160s, over hundreds to 120s, which is really quite high. And sometimes it's lower, depends on his stress level. He, in terms of motivation here recently, since his father died from cirrhosis, despite 10 years of sobriety. He's kind of been reevaluating his drinking. So I think this may be a window that I can approach his drinking with. Can scroll down. And so I checked the PDMP, his current medications, naltrexone, buspirone, thiamine, lisinopril, clonidine. He also takes esomeprazole twice daily for acid reflux. He takes a baby aspirin 81 milligrams daily, and he uses Trelegy Ellipta for asthma and COPD. So in terms of his medical comorbidities, he has essential and secondary hypertension. And one thing that's actually interesting about him is that his ophthalmologist noted that he actually has damage to his retina from high blood pressure. So it is very much a concern. He's morbidly obese, or as we call severe. I'm supposed to use the word severe obesity. I'm trying to change my terminology there. Severe obesity, BMI is 38. He has secondary polycythemia. I suspect he probably has sleep apnea, but he doesn't want to get tested. He also has gout from time to time. Iron deficiency anemia. I suspect that he either has gastritis or possibly a peptic ulcer. He has a history of peptic ulcer with hemorrhage. He has sinusitis, rhinitis. The current treatment plan, I plan to, it's actually naltrexone, they're 50 milligram tablets, but I asked him to take 2 of them. I don't know if he does. He he says sometimes he does. Sometimes he doesn't. Thiamine, also the chlorodiazepoxide for withdrawal symptoms, clonidine 0.1 milligrams for withdrawal symptoms, and counseling to avoid alcohol binges. I'm doing the counseling. As far as the rest of the case, I think that's pretty much the long and short of it. So I'm ready for questions about this case and comments.
Thank you so much, Dr. Luckner, for presenting this case and including such comprehensive details on this patient. I'll start us off with some questions I see here in the chat, and then I'll volley it over to our hub and the audience. A question from Melissa: Has he ever had a sleep study?
He has not had a sleep study. He has refused a sleep study.
Okay.
So unfortunately not. I'll continue to encourage him to do that.
Okay. And then Valerie had a question: Has he been prescribed injectable naltrexone?
That's actually an excellent question. He has not. And I've talked to him about it initially, and he wasn't interested in it. But I guess one of the things that I'm kind of curious if some of our experts can comment too is most well, I think I can fairly say most patients are not excited about injections of anything, let alone something that is going to keep him from being able to drink at social events and stand out. So he likes the flexibility. How have others counseled in that regard? My strategy is to sort of use this opportunity with the recent passing of his father and say, you've made some progress, but in order to really be healthy and not die prematurely, maybe injections could be more helpful. So that's something that I plan to talk to him about, but I'm certainly open to any comments from anyone who has experience with this.
Thanks, Dr. Luckner. Lindsay, I see your hand is raised.
Yes. So I have had just amazing experience with my Zepbound. I've lost 100 pounds, lost all of the sleep apnea and the overweight and all this other stuff, but it also has like completely killed any want I have for alcohol. It just makes me not think about it, right? That noise isn't there for food, but it's also not there for alcohol. So
Excellent.
maybe that is a consideration.
Yeah, actually, that I didn't even think about that. I think that's a very good point. So I'll talk to him about a little bit more about the effects of sleep apnea and multiple systems in the body and how he might feel a whole lot better if he had some treatment there.
Yeah, the other thing is that it also, because I lost the weight, I'm able to get up and just walk, right? It hurt to walk before. So now I can actually get up and move and do things as well as, just sitting around.
Yes, no, it's very good to treat sleep apnea. It's often underdiagnosed and undertreated, and there are also more treatment modalities available, and GLP-1s even being one of them.
Yeah, I think that's what Zepbound is, a GLP-1. And I got it for weight loss, not for sleep apnea necessarily.
Yeah, so.
He would meet criteria for a number of his illnesses to, if he has insurance to cover a GLP. I just want to highlight that studies are ongoing about GLP's efficacies for substance use disorder, including alcohol use disorder. So currently, there's not a strong recommendation to use them just for alcohol use disorder. But I think given that he has, serious obesity, and then some of these other medical comorbidities that can be treated with GLPs, it's a good try and may align more with his, priorities around, making healthy changes. And then in terms of naltrexone and injectable, I've had patients actually requesting it, not infrequently, usually with a little bit stronger commitment to total abstinence versus just decreased use. So with that caveat, I certainly see that with other injectable depot formulations as well of medication. So a lot of my patients that are on want contraceptive management, they want injectables, so they don't have to think about something every day. A lot of folks wanting PrEP want injectable, so they don't have to think about it every day. So I don't know that it's as hard to sell. I think for him, it may be because if he's wanting to manipulate that dose, he won't be able to. And so he may, come into that conversation. And I like that you're thinking about, dialoguing with him more around, what his ultimate goals are. And I strongly, suggest, I think you're well equipped with motivational interviewing skills, but kind of letting him bring that to the table. So opening up the dialogue, how do you see things playing out for yourself? Having this recent loss with your father related to his alcohol use, and he stopped at 58, you're 40 something, I think.
Mhm.
Where does that leave you, or how are you thinking about that, if at all? Right. And then it opens it up. You're not lecturing him, but it's opening up. And same thing with some of his other health conditions. Hey, what do you see as the link between your sleep issues and drinking, or your acid reflux and drinking? And then the only other thing I was really interested in pharmacologically for him considering is if you've ever considered a GABAergic for him, rather than using clonidine and PRN, chlordiazepine epoxide for his withdrawal symptoms. I'm concerned about the clonidine because of the rebound hypertensive effect.
Yes.
And maybe he'd be receptive, and gabapentin can sometimes help with anxiety. It's not a controlled substance, so he's being tested as a plant operator and then having to explain away these random chlordiazepine epoxides. But I
Yes,
don't know if you've explored that with him.
I haven't. So that's a good idea. I'll explore that.
Yeah.
It's a good idea.
Thanks, Dr. Kowalchuk. Tamikia, I hope I pronounced that right, and if I didn't, please correct me. If you could unmute and share your comment, please.
Oh, yes, ma'am. Tamika, my mom just threw an I in there because that's what she wanted to do, but that's okay. I'm Dr. Starling. I'm a doctor of prepared nurse practitioner. I'm located out in Dallas and homeward bound. We do substance abuse and mental health. We actually do a lot of Vivitrol. And so when my patients are coming out of inpatient and coming out here and outpatient and debating on whether they want to do the injection, the Vivitrol injection, I just say, hey, instead of doing the naltrexone every day, the pill every day, you just got to make that choice once, and you come in and you'll get the injection. And for the people that do want to drink, I say you can still drink on it, but you'll just be able to stop. And that sometimes helps them still take the injection, but some of them, they instead of playing with their pill every time, and it's just more of I say it's more of a safety net. And sometimes I'll let them be able to still get the injection. And that's the experience I've had.
Thank you. That's very very helpful.
Excellent.
So I do have a question, two questions. One, when he talks about wanting to get off of the alcohol, does he say why he's wanting to get off of it? Are there specific goals that he has with that? Is it an external pressure, an internal pressure? Does he have a specific health goal? Like, has he ever broken it down into the specifics that he wants to come from stopping the alcohol?
Right. So in the past, I've approached it from a standpoint of, your blood pressure is 160 over 118 today. It's really quite high. It can cause, heart disease and also strokes. How do you feel about that? And he'll give me his information about it, and usually it means that he doesn't want his blood pressure to be that high. So then we talk a little bit about the medication. He is taking medication for it, but then there's also this alcohol component. If you drink heavily and when you don't drink, your blood pressure tends to go up. It's sort of almost like a withdrawal type symptom. And so I've approached it more from a standpoint of let's prevent strokes, let's prevent health problems. Would you be interested in doing that? So I've kind of been pushing him a little bit to do this. He hasn't come to me and said, you know what, I don't want to drink. Um, he that's why I put him down as pre-contemplative. So he alcohol is a big part of his life. It's a daily part of his life, and he really feels like he can't function without it. And I've somehow got to convince him that there are other options for him to consider. But unless he wants to, obviously, nothing's going to happen. So now with his father dying from complications related to cirrhosis, even 10 years after sobriety, like the comment earlier, you're 42 and your dad, he stopped at 58 and died 10 years later. Is this something you want to prevent in your life? So it's almost kind of like I can't just say, well, what are your goals? Because his goals are like, I just want to be able to sleep. I just want to be able to relax.
Right, right, right. There
Alcohol.
is,
Yeah, go ahead.
in the motivational interviewing realm, there's a really great acronym, DARN C, or sometimes DARN CAT, that helps elicit that internal change talk of people that are in that pre-contemplative state. So, and there's some great, like, what kind of questions to ask to walk them through each point of that to kind of lead the horse to
Yes.
water, if you want to look into that. And then the second question I had was regarding the naltrexone. So, have you discussed with him on the days that he decides not to take the naltrexone because he wants to drink, why he's doing that? Because I've had a couple of instances where my clients think that all medications that are written for alcohol use disorder are antabuse or disulfiram. And so they think they're going to get really sick if they take the medication and drink on top of it. And giving him that education, like, that's not going to do that. The
Right.
medication is just going to prevent you from potentially going overboard if you do decide to drink.
Right. So from what he's told me, he says he doesn't drink as much, and it sounds almost like he's just not, like, if he does, he doesn't feel good or something. There's something about it. I don't know if it's flushing or um, he's not very specific about that, but I may want to ask him a little bit more about that. But it's pretty clear that when he takes the naltrexone, he's not able to drink uh, 6 packs of beer. It doesn't work for him. So, but it just all gets back to what you were asking with the first question. It's like, what is his motivation, and sort of giving him guidance, but at the same time not pushing him to not drink, because that's not going to work.
Thanks, Dr. Luckner, for that added insight on this patient. I do want to give a moment to Dr. Walker for a summary of recommendations that Dr. Luckner you can take with you, and that way you have that. So, Dr. Walker.
Absolutely. We had a really complimentary case and didactic today. We got to see not only Dr. Kowalchuk's big brain, but also her comedic chops with the how to toast the holidays without getting toasted and the raccoon bit. Some nice chuckles going into the holiday because we can make our job light and airy because we're in this for a lot of reasons. And then Dr. Luckner had an excellent case about a 46-year-old man who's in a pre-contemplative state, has a lot of family history, a lot of medical comorbidities, complicated case, and he has been trying to lead him to a state where he is going to decrease his alcohol. He has tried a couple of medications, naltrexone, thiamine, Librium, clonidine, as well as the medications for his comorbid conditions, buspirone and PPI for acid reflux and peptic ulcer disease. Some suggestions from the community were, again, looking into more motivational interviewing techniques to get that fire started within that patient, because we can tell them all day long what's going to happen if they continue to drink, but unless they have that internal motivation, it's going to be challenging. Resources were put into the chat for that if you guys want to grab those. We also discussed a couple of other medications like gabapentin use. We also looked at injectable naltrexone in lieu of PO naltrexone. We also talked about GLP-1s or GLPs for the use of substance use, which is not FDA approved. There's a lot of studies going on, but because of this individual's comorbidities, there's a lot of promising things on the horizon that it could be a multimodal approach to treating multiple conditions at once. All right, that's in a nutshell what we learned today, and thank you all for being here.
Excellent. Thank you, Dr. Walker. Thank you all for attending today's session, to Dr. Kowalchuk and Dr. Luckner for the respective presentations that were so complementary to one another. As a reminder, to claim your CME credit, you must text by midnight tonight. Text attend 10101 334 to 844 502 1338. And we also kindly request that you complete the post-session feedback survey using the link in the chat. We look forward to seeing everyone at our next session on January 8th. Have a great rest of your week and happy holidays, everyone. Stay safe.